Started. Welcome everyone. I know other people will be joining us. This is very informal, so it's not like some presentation that's scheduled for. It's scheduled for 6, and we have been here before 6. So, but we also let people know it's okay to come in sometime, after 6, in case they're coming back from work and they have other things that they need to do. That if you're not here by 6 doesn't mean you cannot log in. So feel free to send a message to, others who you may have told about, the office hours for today, and hopefully they'll be able to join us. So we're going to get started. My name is Olihe. I will be kind of moderating just from the background. And today, really, just to give you context, office hours are going to become a regular thing that we do to give opportunity for us to come together to discuss topics concerning, around health. But right now it's COVID that's happening. So of course, our current topics will be focused on COVID. We want to educate ourselves some more. We want to have the right information. And we also want people to be able to ask questions and get answers. So today we have Dr. Glenn Simmons. We're focusing on the science of vaccines. I could say a couple of things about Glenn. Glenn, you should be praying that I don't say anything bad about you. But
My fingers are crossed.
so Dr. Simmons is an assistant professor here at the School of Medicine, University of Minnesota Duluth. He's a molecular biologist, and his research focuses primarily on cancer health disparities, but he does also some community research. Um, but he's a lab person, so most times you'll find him in the lab. And currently his lab is actually involved in COVID-19 surveillance through the municipal wastewater across the state of Minnesota. So that's also another interesting thing, because of COVID, we have to kind of engage and also do research on what's ongoing that will be helpful. So, but today he is going to be talking to, and he's a lot more than just a scientist. I want to also add, I like people bringing their whole identity to a place. So, from what I know about him, he's also a family man. Um, he's also an artist. He also mentors young people. So, he has many sides to him. But today we are having him here as a scientist, and he will be talking to us about the science behind the vaccines, the COVID-19 vaccines. So, I'm going to turn it over to you, Glenn. Um, Take it away.
All right. Well, thank you so much for that, Olihe, and thank you for not embarrassing me. I appreciate it. So again, this is we theme these meetings as office hours, and for those who have ever had the need to talk to a teacher after class or before class to get an idea of material that they may not understand, that's kind of the idea that we have here. So it's not really designed for me to be completely, on a stage in that kind of a sense. It's really to lay the groundwork and then kind of stimulate a conversation, stimulate some additional thought processes in the audience. For those of you who are kind of familiar with me as a person, I talk a lot. So I can keep this thing going, all on my own, but that's not the intent. The intent is to have more of a dialogue and to answer questions that folks may have that they haven't really gotten satisfactory answers for, or to kind of get a better understanding of the answers that they have already received. So myself, as Dr. Okoro had already mentioned, I'm a molecular biologist by training. I have a background in infectious disease, cancer biology, epigenetics, so I do a few things. And so when it comes to talking about vaccines, I come at that from a position of someone who teaches immunology in a medical setting, in a medical school setting. And so what I'm going to try to do first is just lay a very basic groundwork to the immune system in a really, really small little bit of that. And then kind of how vaccines work, the point of vaccines, and then some of the technology that underlies the vaccines that most of the people are talking about right now, which are the two mRNA-based vaccines from Moderna and Pfizer. And then we'll also even talk a little bit about the Johnson & Johnson vaccine that's recently gotten emergency use authorization through the FDA. So that's how we're going to kind of set the stage. I'm going to take probably about 10 minutes to do that, and then we'll move into kind of more of a dialogue kind of a format from there. Everybody good with that? Now, since we're on Zoom, if you don't have your camera showing, I'm expecting to see some thumbs up, okay, or something. All right, cool. All right, so I will share my screen in a second. Let me get to, yeah, let's get here. All right, so everybody can see that. So again, vaccines, super duper important, but not many people have actually had to learn about how vaccines operate. So it's in our face all the time now. And I know a lot of people are asking questions. A lot of people are worried. So we want to make sure that we acknowledge that. So I'm going to try my best to give you just enough information so that you can get an understanding of what we're talking about when we say that vaccines are doing, doing this awesome job of keeping us protected from diseases that could otherwise be very detrimental to our health. All right, so vaccines as a whole, I don't expect you guys to read this, but I'm just gonna give you some bullets for those who don't want to listen to my sultry voice over Zoom. So vaccines as a whole are a very ancient type of medical technology. They are based on the idea of introducing small amounts of things that are potentially dangerous and allowing our bodies a chance to learn how to fight them, okay? That's the basic premise of a vaccine. And the thing about it is that we've been doing some version of vaccination for thousands of years in human history. So it's not something that just originated from, so-called allopathic Western medicine. This is something that originates to ancient India, ancient China, ancient Africa. So we have that history that we're really kind of leveraging when we utilize vaccine technology as a public health strategy. When we use vaccines, what we're trying to do is introduce parts of these microorganisms, microbes, that usually are recognized by our immune system and tells our bodies that there's something in our body that we were not born with that could be dangerous. And what happens is that basically creates a antibody response, or your body generates antibodies. And so that part of that pathogen is called an antigen because it generates antibodies. You see how we did that there? So antibodies are generated once our bodies are exposed to antigens. And so vaccines' main role is to help our bodies produce these antibodies that will basically act as a surveillance system to keep us protected from having things infect us and establish, basically establish disease in our bodies. Okay, that's the big overview. A lot of text on the page there. And so how does that look? When we have somebody show up, at the doctor's office and they got the little itty bitty needle and they jam it into your arm, what's happening there is that in the skin, you have all these cells that are a part of what we call the innate immune system. So we're born with these cells, and they are basically there to protect us from any and everything that is not normal. Okay, so we got a couple of different populations of those cells. We have these things called dendritic cells, or DCs, and we have these other things, these really cool things that go around gobbling up stuff, also called macrophages. They basically take up the antigen that's in the vaccine, and they deliver it to another part of the body called the lymph node. And that's where you have these other types of immune cells called lymphocytes. So these are blood cells that are designed to basically mount that antibody response. So you have T cells in that population and B cells, T and B. So the macrophages and dendritic cells take antigen to the T and B cells. When those cells communicate, they become activated, they become educated, and they learn how to recognize that antigen. They learn how to recognize those microorganisms. Does that make sense? All right. So once that happens, you then have cells that are now going to help mount that immune response, produce those antibodies, and also produce a population of T cells that are going to help get rid of any cells that are already infected. So you basically have a two-pronged approach. You'll have cells that are going to do the job, and you'll have these little molecules called antibodies that are going around floating through the blood, also doing the job. The most important thing to understand about when we're talking about vaccines is that when we do this, we're going to need to produce cells that are going to always be around producing antibodies, okay? And in order to do that, you have to create cells called long-lived memory B cells. There we go. All right,
Okay.
just taking care of some muting there.
Yeah.
So these long-lived memory B cells are going to stay with us and help us keep antibodies going at lower levels later on to make sure that if you ever see that bacteria, that virus, that microorganism again, the antibodies will be ready to help protect you, okay? So let me get back over here. There we go. So how does that look? Now, this is very oversimplified, but the point is that when you get that initial exposure, okay, let's say this is when you get your first vaccine. So the first vaccine happens here where we have the little antigen A box. Your macrophages, dendritic cells, they're going to respond. You're not producing antibodies during that time. So that's like that first 10 to 14 days. You're not really having a strong response there. Toward the end of, or toward the middle of that, you'll start to see them start to produce antibodies. So that's when you have some protection. So if we think about the Moderna or the Pfizer vaccine, all the clinical data suggests right now that you're producing some protection during that first vaccination. Okay, so it takes about a week, you start to get some antibodies, you have some protection. That's great. Now, you get the second vaccine, the second dose for the Pfizer vaccine, I believe that's 3 weeks, and for the Moderna, it's about 4 weeks or 28 days. And that's when you get that really, really strong response, that really strong production of antibodies. The reason for that is that you're not just telling new cells to produce antibodies, you're waking up those cells that already were primed, they already saw the antigen. So from an analogy standpoint, that's almost like basically tripping the alarm and then tripping the alarm again and basically calling in more reinforcements. So the reinforcements are waiting and they knew they were looking for something and they're going to show up there in mass. It's going to be a massive attack. And so that's really the basis of getting 2 different doses with these vaccines, is to get that initial response and then to get that boost, that booster type of response. You get more antibodies on that second hit. Now, if you were to get a different type of, antigen, a different vaccine or something later on, shown here, you're going to start from scratch with that particular type of antigen. So that's why it's important to get the same vaccine and in some degree, get the same vaccine in the same area so that you're activating the same populations of cells that have already seen it. That's theoretically the purpose behind that. We don't want to create any brand new responses because then you may not get the maximum antibody response. It's going to give you maximum protection, okay? Now, when we talk about these vaccines, this graph is probably not the best thing here because it's pretty complicated, but we know right now we have the Moderna vaccine, we have the Pfizer vaccines that are made out of mRNA, okay? What is mRNA? Oh, I'll explain that in another slide, but it's basically genetic material. And I'm gonna explain it in a way that, kind of simplifies it from this slide, but I just wanna make sure that we understand that when we talk about vaccines, they come in all different types of flavors. So a lot of vaccines, obviously back in the day before we were talking about these new vaccines that we're using, were based on using dead viruses, dead bacteria. So they wouldn't necessarily get you as sick as a live virus or a live bacteria, but they would help your body generate an immune response. When you're using what we call peptide or subunit vaccines, you're only using a small piece of the entire thing. So you're not using the whole virus, the whole bacteria, you're only using a little bit of it. And that usually will keep you from getting sick. The mRNA-based vaccines are really similar to the subunit vaccines because you're giving one little piece of this virus that is not going to get you sick. Even when the protein shows up, it's not going to make you sick because it doesn't replicate itself. It doesn't infect your cells. It's just a little signature. It's just a little remnant of the virus. And that gets your body, primed to recognize it when it sees it on the whole virus, when that whole virus shows up later on in life, okay? Then you also have these other types of vaccines like the Johnson & Johnson vaccine, which is what they call a viral vector. So it's not a coronavirus, it's kind of like a cold virus. and it's been modified to carry the DNA of the same molecule that comes in the Moderna vaccine. So it's still that same subunit, that spike protein. And the virus can infect the cells in your body, replicate just one time, enough to get inside of that cell, produce the protein, and now your body will see the protein expressed on some of your own cells, and you generate an immune response. So it's a very similar process, just slightly different, and some of those dynamics are tied up in some interesting immunology, biochemical concepts, and we can go into that if somebody really feels, froggy enough to ask that question. But for the most part, it's the same concept. It's just a different type of molecule. And so, pictorially, just to kind of show you, when we talking about this whole idea of an mRNA vaccine, you almost want to think about it like a bubble of fat with this molecule called mRNA inside of it. That fat layer, that lipid layer that is on that particle, allows it to be taken up by cells. It can get taken up by the dendritic cell and the macrophage, so they can gobble it up. Once it's inside, that mRNA basically gets processed into a protein. It becomes a protein because there's this thing called the central dogma of biology, where DNA turns into RNA, and the RNA becomes protein. So the whole point of us using the mRNA is so that we can make the protein the exact way we want, so that it can become recognized by our immune system. And so it goes through all of these processes just to get shown to the immune system on the cells in our own bodies. So, okay, I don't have that other slide here. So I'm going to stop there. Because I'm sure there are questions that people already have. I think for the most part, I covered everything that I wanted to cover, so that the dialogue could maybe start from the same place, so that everybody might be at least at the same starting point. And if you're not, I'm sorry, and that's my failure as a teacher. But I think it's important for us to at least kind of have some of the same basic building blocks for this session to be useful to everybody on it. And I'll keep the share screen up just so I can go to things if people want to reference it.
Yeah, well, thank you so much, Glenn. That is, actually just very enlightening, even for some of us who are in health but are not, in immunology and are not steeped in that science. That's very helpful, especially the graphics to actually see that. So if we have any questions, I will ask a question that I've heard, and maybe you can speak to that. So speaking about the mRNA, and then comparing it to, vaccines where you get an attenuated, that's the kind of deadened, virus. So the mRNA, can it cause, that's one question people keep asking, can it cause you to be sick, since it's this component, that's taken from the virus that then is turned into a protein, can it make you sick? Because that's one thing people are wary of. Like, if I go get the vaccine, can I actually be sick? Then what's the difference between getting the vaccine and just getting COVID?
So now, if we look at the data that's associated with the clinical trials, there are situations where individuals who receive the vaccine have certain types of symptoms. Those are not symptoms that are tied to being sick with the virus. So it's not a COVID-like symptom. Those are usually symptoms that are more so related to hypersensitivity, where your immune response is just responding to the fact that there's something foreign being introduced into your body. And that's very common kind of across a lot of vaccines that are out there. So it's not necessarily unique to these mRNA-based vaccines. The mRNA itself is not capable of making a person sick, because it, in fact, isn't a part of the virus that makes you sick. So again, it's almost like imagining, you think about a house, okay? Think about a house. So you have this entire structure. And the first thing that you may recognize a house by might be a chimney. If you see a chimney on a building, you might think that that's a house. It's just sticking there. It's very distinct. But that does not necessarily mean that you can live in a chimney. It doesn't make up the entire structure. It's just one piece. The spike protein is just one piece that happens to stick out. So it becomes something that's very obvious to our immune system, as opposed to all the different proteins that are inside of the virus. those are all kind of cloaked and hidden from the immune system. And so that's all this being introduced. And the mRNA is made in such a way that it's a specific, I think it's 2 different mutations that stabilize that protein. So that's in a very specific conformation, a specific shape, so that our immune system will recognize only the virus before it's ever even primed itself to go inside of our cells. So it's basically like, oh, I just showed up to the party and it's getting kicked out. As opposed to, I showed up to the party, I already made it to the punch bowl, and I'm in your refrigerator. Like, no, we stop you at the front door.
At the door,
Because
yeah.
exactly. So that's what the mRNA is able to do.
That's good to know. So questions?
To raise a hand.
Okay, is
Go
there a
for
hand
it.
up? Yeah, go for it. Just unmute yourself and ask.
Okay. Right. Thank you so much, Glenn, for informing us, and teaching us all this. Man, so since we have 3 different types of vaccines, Pfizer, Moderna, and J&J, and each one of them, we are told of the different, effectiveness. It sounds like, if I were to label them, really, it looks like Pfizer has, a higher percentage, and then Moderna, and then J&J is pretty low. And with that, seeing that or hearing about that and listening, of course, it causes a lot of anxiety, in that I know also the very one that has the least effectiveness, we are only going to get 1 dose of it. That is Johnson & Johnson. So after you showed us, I think when you're showing us the graph, when we get a first dose, what happens in the body, and then we begin to build the antibodies and so on. And then the second dose, I see that in the graph, it was pretty high. And then I became worried, like, okay, where is J&J there when the effectiveness is pretty low, yet I'll be receiving 1 dose? If you could just break them like that, and then just maybe, I don't know, to gain better understanding and ease up.
That's actually a really, really, really good question. One thing I will say, and this is, kind of the public health side of me, any protection is better than no protection. That's first and foremost. So I would not say that anyone should consider turning down an available dose of a vaccine. Now, the researcher side of me, the scientist side of me, has to make sure I next say that it's very difficult to compare the different types of vaccines, because the way the trials were measured were different. The way that they were doing their analysis was slightly different. So Moderna and Pfizer, you could compare them more or less because they're very similar. The trials are similar. The structure of how they did the study is really similar. The Johnson & Johnson vaccine trial is very different. When they were doing their analysis, the time points are very different. So they were actually, in some ways, I would say almost overly cautious in how they're reporting their results, because they're only doing 1 dose and they allowed a certain amount of time to happen before they would actually look to see if people were affected. Whereas with the Moderna vaccine, they had multiple time points that they could look: 7 days after the first dose, 7 days after the second dose, 28 days after the, so they were basically measuring at multiple time points, and they recorded all of that. Whereas with Johnson & Johnson, they only got 1 chance. And so they actually kind of waited, I would say, a reasonable amount of time after that first dose. And then they would say, how many people in the placebo, the folks who didn't actually get the vaccine, how many people who did get the vaccine got sick? And the other thing that has to be stated here, and for any of scientists or physicians on the call, I definitely chime in if you know differently. They only, I believe all of the trials, at least definitely Moderna and Pfizer, they're only looking at folks who were symptomatic. So that means that you also may have folks who are actually sick and we never see them because we're not looking for them. I'm not 100% sure about Johnson & Johnson. It's been a little while since I've double checked that study, but it's a lot of nuances there. So what I would say is that we should definitely not get too caught up on those numbers, because the folks who were able to benefit definitely benefited. Okay, so it wasn't like there was no benefit. And then there's also the technology that goes into the vaccine. I'm sorry this answer is taking so long. The technology that goes into the vaccine with adenoviruses in particular, because it's something that everybody has been exposed to at some point in their life, it's possible that there's a certain amount of pre-existing immunity. And so that may actually affect how well the virus survives in our bodies to do the job that it's supposed to do. That has not been determined how much that's actually happening, but it's something that's known, because with adenoviruses as vectors, I think back in the 90s is kind of when the technology was really, really hot, and they were doing this thing called gene therapy. And one of the reasons why, well, actually there was a really, really bad adverse event that happened that made them stop it all. But one of the main things that made it really hard to make it viable as a widely used treatment was that people have pre-existing immunity to these viral vectors, which would basically mean they get cleared out before they could do their job. Whereas with the Moderna lipid particles, some people have some hypersensitivities, but it's not something that's very common. So our bodies aren't necessarily used to it. So our bodies generally just kind of treat it as though, it's just some inert molecule in the atmosphere. Oh, it just happens to have some mRNA in it. We developed an immune response later. Whereas with the adenovirus, it's possible that we may have conflicting situations going on where our bodies, some people are more immune to them. They don't get a good response. Some people may not necessarily, they get a better response. I think they're going to continue to monitor the folks who've gone through the trials to really determine and ascertain all that additional information that we weren't able to get in these early data that they've released so far.
Yeah, thank you so much. That was a really good question. Yeah, and some clarity there. And I just want to emphasize the first thing that you said. Any one that
Any
you're able
protection,
to, any protection that you can get is worthwhile. Yeah, it's better than nothing. I think about it almost like, the way we think about um, exercise. I mean, even if you can do 5 minutes, if you can walk for 10 minutes, whatever, anything is better than just being on the couch the whole day. So,
right?
so
right.
yeah, anything that we can get. But that's a really good question, because well, I'm going to have I do have some questions, but I will, let others ask questions. And I know we have Dr. Judith Christensen here too. She's not an immunologist, but she's a physician. And so, Dr. Judith, if you want to weigh in at any time too on, some perspectives that you have, knowledge that you have too around the vaccines, please feel free to.
I have unmuted myself. Hello.
Hey.
I think probably the part of the newer vaccines, so newer meaning we didn't have other mRNA vaccines FDA authorized before this one, but it was some technology that had been explored in the past. I think the thing that is the most interesting is the concern that we are going to put this genetic material that could alter people or change them. And the funny thing about mRNA, and the M means messenger. So it's just the messenger. It's like a set of instructions, like a recipe. And then the body uses its own equipment, reads the recipe, bakes the cake that happens to be a spike protein. And then before we know it, we can't even find the recipe because it's actually been dissolved or degraded by the enzymes of the body. So I think that concern about it being this lingering, concerning molecule, fortunately can be put a little bit to rest with the knowledge that mRNA is actually fairly unstable. It doesn't last too long. So it delivers the message and then finissimo. It has also been a while since I took a look at the data for the individual studies for the vaccines. However, two things. Number one, my understanding was that the response that they wanted for them to say the vaccine was effective, like Moderna and Pfizer they like blew it out of the water. Nobody was even expecting that. So we would have still been happy with like a 70% response. And these guys come in talking about 95 and 96. So all in all three that got approved more than met the metric that the FDA was looking for us to say that they were effective. And then furthermore, and I try to wrap my head around this as well as I read, these comparisons, it really seems like much of the power of the vaccine is in us analyzing those who were vaccinated with each of those three, that, and I'm hoping I'm quoting this correctly, that they were all three at like 100% effective against like severe COVID and death. So they start to stratify when it comes to severe versus mild, moderate, and some of these other areas. But when we're talking about the stuff that I think has most of us pretty concerned, ICU admission and possibly not surviving, that's where they really show pretty equivocal protection from my recollection. So
yeah,
I support the statement of not trying to hold out or thinking that you're going to be shortchanged. I think the 2 doses versus the 1 also may create a bit of a cognitive like dissonance, like, well, oh, is it because maybe I should just get like 2 shots are better than 1? And it really just has to do with the mechanism of how they designed the different vaccines. And in a way, Johnson & Johnson, they were kind of like, they took their time, they were extra cautious. They're like the last kids to come to the dance, but they kind of come with a game-changing approach, because the logistics of getting individuals back for a second dose of a vaccine, which is doesn't have great longevity at room temperature, made the rollout pretty clunky for the first 2 vaccines, because it just takes a lot of logistics. But Johnson & Johnson's approach was, let's get that person here, let's get the shot in, and they do not have to worry about, am I going to make it back for that next shot? What's going on related to that, timing, having the medication go bad, all these stories you've heard in the media, because it's also able to survive and be viable for a longer period of time at more typical temperatures. So I wouldn't hesitate for either one of them to have that protection from severe COVID.
yeah.
Thank you so much.
Absolutely.
Yeah. Thank you so much. Yeah, I think that really puts people's minds at rest, because those are some of the things, I even just had someone ask me this week, like, oh, they had signed up to get, but that they're getting this one and that they heard that this one was, I'm like, you got to come and get the information. Yeah,
Mm-hmm.
it just clarifies things for people. Yeah. Other questions?
I have a question. My name is Cheryl, and I'm the risk manager at the Duluth Y. So sometimes they call me the queen of COVID, because I'm the one that's answering all of the questions in our organization about what we should do and all of these things. And so lately I've been getting a lot of the questions about, should I get the vaccine, and kind of starting to have conversations with staff about, who are looking for more information about the safety of the vaccines and things. So I have really appreciated the information here today. That's going to help me a lot. The questions though that I'm getting that I don't know how to answer, are people are worried about long-term effects of vaccines. And so they're saying they're not going to get the vaccine because they are concerned about what effects this vaccine is going to have, 1 year down the road, 5 years down the road, and all of those types of things. Is there any information out there somewhere about those types of things? I know that it's really early in all of this process, but if there's anything out there, I would appreciate it.
So the first thing I would say is that long-term effects of the vaccine, like, we don't have that data yet, because the vaccines haven't been out long enough. I will say this just so that everyone understands, the trials are still ongoing for all of the vaccines. I believe at the very least, for the Moderna and the Pfizer vaccines, they have at least a 2-year additional monitoring period for all of those who are enrolled. And so that's, I think, collectively like 120,000 people. Not to mention all the people who've already gotten the vaccines and who are tied into the continual monitoring applications where you can just report any type of adverse effects that you may have. Now, in terms of being concerned about the long-term effects of the vaccine, I would probably, just caution people to be more concerned about what we do know about the long-term effects of actually contracting COVID. And we still haven't fully wrapped our minds around that. So instances where individuals who have contracted COVID and have recovered and still having symptoms that are not able to be dealt with through any type of mitigation through the healthcare system, because in some cases, as far as we know, the damage is done, and we have to now figure out how do we fix that. So things like the fog, the COVID brain, or the fog that's associated with that, the damage that's associated with damage to the lung tissue, damage to cardiac tissue. So, I mean, long-term effects in your breathing and your regulation of your circulatory system, those are things that we know exist, and we haven't had enough time to see just how bad that can get. But we know that even in this year's worth of time, how detrimental that can be. And especially looking at things that have happened with young people who we know tend to have less severe issues with the actual acute infection, but having cases where young people have come back into some type of medical care because of some other issue that has manifested after they've had a positive diagnosis with COVID. So I wouldn't say that we should be looking for long-term data yet because it's not there, but compared to, for anyone who's not in healthcare, who's not a practicing healthcare professional, I would say that the general public has more access to data on each of these vaccines than in real time compared to any other vaccine and probably any medication that people have ever been exposed to in the history of the world. And that is probably not an exaggeration. It's probably, this is probably going to be a lot more normal because now we're all being educated about what the process actually looks like and where the speed actually happened. Because a lot of the speed that goes into approving drugs, a lot of it is regulatory. It's not that the scientists move any slower. It's also when the public awareness actually is very heightened, and you can enroll patients more readily because they're eager to be involved. Because the numbers are the numbers, the statistical power that you need to do these studies, they didn't skimp on any of that. But the ability to say we need adults who can consent to doing the study, who's in, and then you have 30,000 people show up. We were doing at the University of Minnesota, I know that they were doing enrollment for the Novavax formulation for a COVID vaccine. I saw the email show up on a Monday, and I promise you, by the next week, they were like, we're done. We have everybody we need for this site. So I think we should definitely think more so in terms of the long-term effects of actually contracting COVID, even if you don't have an ICU visit, even if you don't have a severe case of it. We do know that there are things that are happening to people that we're just now starting to understand. But we have a lot of data on what these vaccines are currently capable of, and we're monitoring and keeping track of those who have taken the vaccine to make sure that we understand it even more completely later on and into the future.
Thank you
Yeah,
so
thank
much.
you.
So it's a risk benefit, and you're a risk manager, so hopefully now you're kind of, better armed to respond to that. We have a couple of questions in the chat. So one is, and other providers on the call, I can see Dr. Trok is also here. So one of the questions, Shay wants to know if there's a number of vaccinations that would provide herd immunity, or whether it's recommended for everyone to just get the vaccine, everyone that's eligible to get the vaccine. So is there a certain, proportion of the population that if once they get vaccinated, we're good, versus, or should there be a push for everyone who can get the vaccine to get it?
So off the top of my head, unfortunately, I don't know the exact number. And if somebody else does, please speak up. But I do know that the number is pretty high compared to other things that we may have experienced in our lifetimes in terms of infectious disease. And so the idea of herd immunity is largely tied into how transmissible a particular microorganism is. So the more transmissible it is, the higher that percentage of people you need to be immunized against it. And so I believe the number is upwards of 80, maybe even upwards of 90% of the population needs to be protected, because we know, or at least those who can receive the vaccine, so that those who cannot receive the vaccine are also protected. So it's a very high number, and it's not an easy thing. So we haven't been, using the term herd immunity a lot, mostly because for us, the herd is almost everybody. So it's almost like you don't really want to get people into trying to play the math game. Everybody who is able to receive the vaccine should get the vaccine based on how highly transmissible this particular virus is.
I need Dr. Trock, did you want to weigh in on it?
Yeah, sure. Yeah, sorry, it took me a while to get the unmuted there, but yeah, Glenn is 100% right. It's really, really a high value. It seems to vary as far as we know in terms of the particular disease that you're dealing with. But yeah, it's got to be very, very high. And even with really high levels of herd immunity, we still see random cases of measles spread around. So it's not a perfect answer to rely on herd immunity by any sense. And I think you really do have to take your own health into consideration and take control of your own health in this sense, and not rely on everybody else to take care of your health for you. So yeah, I'd absolutely endorse the vaccine 100%. And to go back, I missed a little bit of the beginning here, but I did catch Dr. Simmons' explanation about the risks of actually getting the disease versus the risk potential that we don't even know about yet of the vaccine complications. And I would like to echo that. I see that in the hospital quite a bit. The elderly folks who've had the vaccines, I've seen people get weakened by them and need to come into the hospital, but they generally leave within a couple of days. The elderly people that I've seen coming in with the actual disease or the subsequent complications from the disease, those people have done extremely poorly with time too. So just anecdotally, there's no question the trade-off between taking the risk of the vaccine, which is extremely minimal, versus the risk of the disease, which is extremely real. There's no question. It's the vaccine any day. So.
Thank you so much.
Sure.
Yeah, so we have another question. For the individuals that have already gotten COVID-19, is it recommended to get the vaccine, or should their body have developed antibodies in response? So what do you have to say about that?
Yeah, they should absolutely get the vaccine. Yep.
Yeah, basically. I mean, there's a lot of stuff we can talk about in that, but unless you're in one of my classes, I'm not going to go there. You should get the vaccine. Now, there definitely are some public health considerations to have there, but because we know that getting the vaccines is difficult for a lot of people, unless you are actively dealing with COVID, unless you are actively sick, positive case like yesterday, diagnosis, it's recommended that you should get the vaccine. And the short answer I'll give you into the underlying mechanisms is that everybody's response to the infection is not the same. But we know that based on the science of the vaccines, that it's designed to give you a high antibody response, a high protection type of response. And so if you only rely on the idea that getting infected will protect you, that means that you do not know how much protection you have. You don't know how long it will last. And that basically puts you at risk. Okay. And, for me, just, kind of the good Samaritan in me, I would like as few people to be at risk as possible. And the vaccine is one of those mechanisms, along with all the other public health mitigation efforts, like wearing your mask, social distancing, and not being in large crowded spaces indoors.
Yeah, thank you very much. I would echo that. Dr. Judy, did you want to add something?
I'll echo that sentiment as well. I mean, certainly the prevalence now of variants really speaks to the need to get the vaccine campaign rolling, because those who had been infected, however many versions of COVID ago, their body may not necessarily be able to mount the kind of response that they need to do well with a second exposure. In terms of the after effects of infection with COVID, fortunately, I am not getting too many calls in that regard, although my spouse, who's an interventional cardiologist, certainly is, he's been a little bit taken note of the number of individuals who were not necessarily very ill with COVID, but still have lingering kind of unusual dysautonomia, heart racing, feeling winded for no reason. Medical workup comes back saying like, sorry, just going to kind of have to see how long it takes to feel better. I want to say, there are studies that they're showing somewhere upwards of like a good 30% of individuals having ongoing symptoms in, a number of different areas, long COVID. When I read that, I thought those are actually not really awesome odds. You have like a 1 in 3 chance of still being poorly, not doing so great after infection. Contrast that with, I don't know who has the number right now of how many millions of doses of vaccine have been administered, and we're not seeing a parallel in terms of concerns for harm here and now. And indeed, we do not have the data on what the future holds after vaccination, but I do know that right now I would like to not contract COVID. So that's pretty much the explanation I give for those who ask me similar questions.
Thank you very much. Other questions, please, just anything at all, because we really want to be able to clarify anything. There's no question that's too anything.
Hi, doctors. My name is Emily and I work at WDIO. Thank you so much for doing this. One question that we have gotten is, can people who have been vaccinated see people who have not been vaccinated yet? Would it be safe for them to do that?
Okay. The only reason I'm going to respond first is because my name is on the flyer. Oh goodness. No, not without the same mitigation efforts that have been put in place from the beginning. I actually sit on the other side of the fence from the most recent recommendations from the CDC. I will go on record saying that, not because I don't think that it's possible, but because we're talking behavioral, we're talking psychology here, and we don't know what everybody else is doing. And we do know that 95% effectiveness in terms of, the idea of people, having a transmission and contracting, the virus, means that there's a certain percentage of people who do end up positive, even when vaccinated. And that does, like Dr. Christensen said, that protects them from the worst case scenario when they have it, but that doesn't necessarily guarantee that there's not some amount of transmission. It may be lower, but it's still there. I have people in my life that are immune compromised. So I'm extremely, extremely careful around them. And even once they're vaccinated, I'm still going to be, hey, you're over there, I'm over here, I have on my mask. Because the work that I do day in and day out, I know that my exposure is a lot higher than your average person. And that is just an unnecessary risk. So I would tell people, continue to practice the same, social distancing practices, keeping yourself at a safe distance, because again, we don't want to play the odds game. It's just not the good time for that, because as cases start to come down, we want to keep that trend going. And the only way to do that is to kind of stick with the things that have worked as we add more tools to our arsenal to fight this disease.
Yeah, I would completely agree with Dr. Simmons on that as well. I'd like to add a little bit to that too, in that, some of the statistics about the efficacy rates of the vaccines don't really include the variants that seem to be coming out, and it seems more and more mounting evidence that the vaccines aren't quite as effective with these new variants. It depends on the vaccine, I guess. But so with that being said, since we don't know that, I would completely agree with Dr. Simmons and say, yeah, I think we have to keep doing what we're doing for now. This thing isn't over. We've made some definite progress, but we're not at the end of this thing yet. And just as kind of a side note too, anecdotally, this year I have not yet admitted a single patient with influenza. So we're doing ourselves a favor by doing all these efforts to mask up and keep our distance from people. Other transmittable diseases like influenza and other just respiratory and viral illnesses that can hurt people pretty badly, and as everybody knows, influenza kills a ton of people per year. That has dropped off considerably this year. So it's not just the COVID that we're helping ourselves with. It's a variety of other diseases that have been hurting Americans for a long time too. So this is a good time for us to continue stepping up and to really protect the people who are most at risk. Even if we've been vaccinated, I would fully agree with Dr. Simmons. Keep your distance, keep your masks on for now. This thing is not stopped yet.
Thank you very much. Yep.
I'll be the third one to chime in and just say, if you look at the whole country, right, we've been trending down, and then we started to slow. So like national daily rates. So even where we are right now is still actually from like a national standpoint, at least, an unacceptably high degree of transmission. So we're still liable for essentially baking and perfecting more and more advanced variants. The more bodies this virus goes through, the more it reconfigures and it gets more clever. So I support that idea of us doing just about everything we can right now to put the kibosh on that, because I think that a little bit of extra masking now could buy us a much more mask-free future down the road.
So an abundance of caution is what I'm hearing. Let's just continue to do what we have been doing. Yes. Other questions?
Don't be shy. If you're in the office, you have to ask one question, or at least turn on your camera and wave.
I have one, if that would be all right, Dr. Glenn and other doctors. Thank you. So I have some autoimmune challenges, and my husband is worried about me getting the mRNA vaccine. He's worried about my immune system being maybe hypersensitive already, and especially kind of those longer term effects, especially because people with autoimmune issues, from what I've read, didn't participate in many of the trials. So just wondering if anyone has read anything or has any knowledge about the effect of autoimmune challenges, a hyperactive immune system with the mRNA vaccine.
So I'll try to be brief on this point, and somebody definitely tag me out. You're right. So that population was not specifically focused on, and if you lack the ability to mount a normal adaptive immune response, you would not be a good candidate for a vaccine, period, because that's what the vaccines are designed to do, is to elicit the immune response. Now, if you are having a hypersensitivity response, then it's going to depend on what type of hypersensitivity response. So like there have been cases of individuals who have, because hypersensitivity basically falls into the category of allergic reaction, right? So if we're talking about something like that, that is something that you have to discuss with whomever you're in the care of to understand exactly what's happening, because there are situations where people have had very severe responses, and there are situations where people have had these mild responses. With the Moderna vaccine, as an example, not with the Pfizer, but the Moderna vaccine, there have been instances of what's called COVID arm, where people have essentially almost like a poison ivy type of response in the arm where they receive the injection. That exists. I'm saying this so that when people see it, they don't say, Dr. Simmons never said that. It's like, no, there are things that happen. Now, about that, it essentially seems to be, it falls into the realm of a true immunological hypersensitivity that is almost, I would imagine it's probably like IgE mediated. So it's something that can be dealt with something like Benadryl, antihistamine. So it does subside. And every individual who has gotten a first dose had that response. They took the treatment to deal with that. It subsided. They got their second dose. And thus far, I have not come across any evidence that there's been anything else. But first and foremost, you would have to be able to define exactly what your type of immune condition means, because that will dictate whether or not you're going to have any type of issue that needs to be monitored. And that was my short response.
Yeah, and of course, definitely I want to highlight that, having a conversation with whoever has been managing your care, because they know your history and they know more about that. And I'm sure they probably will be able to better direct or advise.
Yeah, I don't have the answer to that one, but just knowing the different avenues by which people can receive the vaccine, that sounds like, for somebody who has that concern, a place that is more like a medical facility with rescue medications if they were ever to be needed, as opposed to something set up like a drive through, get the shot, drive down the road. You know what I mean?
Right.
Just if there's any way to kind of put that into the thought process as you're seeking the location to receive the vaccine, I think that would be a worthwhile thing to consider.
Thanks so much to both of you.
Thank you. Any other questions? Okay, well, if we don't have other questions, Glenn, if you can just put your email address in the chat in case,
Absolutely.
At times people
because I need more email, right?
I know you do.
I'm kidding.
Just in case, if people have, at times something comes up later and you're like, oh, I wish I had thought of that, while I was here. But thank you so much for just clarifying, and thanks again to our other, healthcare providers that, were able to chime in, Dr. Christensen, Dr. Trog, this has been very enlightening. And for me, it's just more confidence in the vaccine. We talk a lot about vaccine hesitancy, and we're now beginning to kind of shift, in terms of how we're thinking, to actually vaccine, confidence. So that it's really, are we confident in this vaccine so that we can go ahead and take it. And I also wanted to mention that we're going to continue to have these conversations. So we have another one planned for 2 weeks out from now. So also be on the lookout for that. And then also continue to check Health Equity Nordland. There's just a lot of information there about sites for vaccination, eligibility. There just a number of questions can be answered just by visiting the Health Equity Nordland website. So we will, in 2 weeks' time, about this time, be hosting another office hours with, providers, and we'll be focusing on mental health. So we'll continue to have conversations around COVID. And even if you have questions about other things at that time, you can still ask. We will have a theme for the office hours, but if there are other burning issues in your heart and you really want a question answered, why not? You can always ask. So thank you everyone for coming.
And really quick, because I know that there are vaccine opportunities that are coming up, I believe March 26th. And for more information about that, just email healthequitynorthland@gmail. Healthequitynorthland@gmail. It's in the chat. If you're interested in just figuring out what category, which different tiers. I try to stay out of that space because it's pretty complicated, but the team at Health Equity Northland is doing an amazing job of finding these opportunities to make sure that more people are basically able to navigate this thing, because everybody's trying to figure it out, and not everyone is necessarily getting access at the same rate. So what we're doing with Health Equity Northland is making sure that we level that playing field as much as humanly and even sometimes superhumanly possible, So a big thank you to Health Equity Northland for the work that they're doing. And obviously visit their website if you want to look around, because they always are updating the information there as well. But be sure to check out the email, because you'll definitely get direct information from them via the email address there.
Yeah, thank you. I'm wondering if Christina, do you want to, mention anything in terms of what's coming up that people may want to know, or how they can?
Hi, I'm driving in the car right now, but
All
yes,
right,
we
that's
do
fine.
cover it, and our next office hours is 2 weeks from now at 6 p.m. And we will be covering, hopefully, psychiatric issues in adolescents and young adults as the topic. So be on the lookout on our website, like Dr. Simmons had mentioned, for that information. We've opened up our vaccine clinic appointments to 45 plus with other health conditions. So if you think you may qualify for a vaccine appointment, please definitely send us an email, or you can send me a text at my phone number at 612-799-8765, and I can get you the most up-to-date information regarding vaccination eligibility, and we can schedule you for a clinic.
Thank you. Thank you so much, Christina. All right. Well, thanks, everyone. This has just been so good. Thanks for coming. Be on the lookout for more information, and please join us again in 2 weeks.
All right, everyone. Be safe out there. Have a good night.
Yeah, and have a good night.
Great.